Well, hello, everybody. Welcome to the latest of our academic seminars. Let me introduce you to Leanne Trick, who is a research assistant professor in psychology. She is Durham University's Applied Research Collaboration Fellow for the Northeast and North Cumbria, and has been an invaluable member of the team that sought to foster cross-disciplinary networking with a view to marrying academic research with real implementation endeavours. Let me tell you a little bit about Leanne. She is an undergrad and master degree in psychology and a background in psychological, clinical and health services research. She's worked in phase 4 clinical trials investigating side effect profiles of psychoactive medicines at the University of Surrey and in addiction research at the University of Sussex, involving experimental studies investigating psychobiological mechanisms of alcohol addiction. And this was all before she completed her PhD, which she did in psychological medicine at the University of Exeter in 2017. So her PhD explored the role of repetitive thinking, such as worry and rumination, in predicting depression amongst people with coronary heart disease. And after her PhD, she applied her knowledge to projects investigating cognitive and disease-related factors involved in depression in inflammatory bowel diseases, most recently working on a number of clinical research projects evaluating the efficacy and implementation of pharmacological and psychological treatments for various substance use disorders at the Centre for Addiction and Mental Health in Toronto. So with such a wealth of experience, we're very, very lucky to have her here at Durham, and I'm very excited to hear about her work in her talk today. So over to you, Leanne.
Thank you, Amanda. I'm just going to share my slides. Okay, so thanks, Amanda, for the introduction, and thanks everyone for coming today. So what I wanted to do is to use this opportunity today to talk about a couple of projects that I've been involved in previously, looking at some predictors, what I think are interesting predictors of depression in people with long-term conditions. And I think this is quite a nice forum for this topic because it speaks to the Wolfson Mental Health Challenge Academy, and also I think it illustrates the importance of thinking in a sort of an interdisciplinary way when you're thinking about the causes of mental health conditions. Before I start, I just wanted to define a couple of the concepts that I'm going to be talking about. So as I said, I'm interested in predictors of depression in people with long-term conditions. So what are long-term conditions? So these are chronic conditions that can't currently be cured, but they can be managed with treatment. And this includes things like heart disease and diabetes. And there are currently about 40% of the UK population living with at least one long-term condition. So this translates really into a huge health burden, not only for individuals, but also for society as a whole in terms of healthcare spending as well. So again, because I think there's probably a bit of a mixed audience here, I just wanted to explain what I'm talking about when I'm talking about depression throughout this talk. So what I'm referring to is major depressive disorder. So this is a really common mental health condition. So it affects approximately 5% of the population globally. And it's got two key defining features. So these are persistent sadness or low mood, and also anhedonia. So this is the inability to experience pleasure or interest in activities that you may previously have found enjoyable. So other symptoms are also common. That can include things like changes in sleep or appetite, extreme fatigue, and other issues around cognition and the way people think. So, for example, problems concentrating. So really this can be very debilitating. So what happens when long-term conditions and depression collide? So why is depression in long-term conditions such a big problem? Well, firstly, it's really common. So about the number of people who experience depression in long-term conditions is about 2 to 4 times that seen in the general population. And it's also associated with worse medical outcomes. So this graph here is just to demonstrate some quality of life data. So this shows a composite health-related quality of life score. The first data point on the graph shows you what healthy participants are rating. So on this scale, higher scores indicate better quality of life. So you can see healthy individuals are rating themselves quite highly. It's about a 10% drop then when you look at participants or people who have a single long-term condition, and that's the yellow circled data points. And then you can see another about 10% drop in ratings of quality of life when you look at the same long-term conditions combined with depression. So we also see worse outcomes in terms of objective markers of morbidity and mortality. And again, all of these problems with physical health result in costs to society in terms of increased healthcare utilisation and healthcare expenditure. So depression in long-term conditions is also a problem because there are issues with treatment. So to begin with, depression is under-recognised, so we're not screening for it routinely enough. And the lack of screening tools often results in healthcare providers missing the majority of cases. And there's various reasons why depression might be under-recognised in people with long-term conditions. I think one key factor is that people are very often focused on physical symptoms and they don't tend to think about their emotional or cognitive symptoms. And that's healthcare providers and patients themselves. Depression in long-term conditions is also undertreated. So people with long-term conditions, very few of them are actually accessing specialist psychological services, and they're much less likely than their healthy counterparts to receive antidepressants or a mental health referral from their GP. On top of this, if people do receive treatment, an additional issue is that the effectiveness of standard pharmacological and psychological treatments in people with long-term conditions for depression is limited. So we typically only see small to moderate effect sizes. So what's the nature of depression in long-term conditions? Well, it's quite a complex picture. So depression can precede the long-term condition, and in some cases could actually be a risk factor for development of a specific condition. On the other hand, depression can arise as a consequence of stresses related to the long-term condition. And actually, in reality, the relationship between depression and long-term conditions is probably a bidirectional one. We don't understand the causes of depression in long-term conditions very clearly. So we know in the general population that there are a number of risk factors or factors that correlate with depression. So things like being female, being younger, coming from a more disadvantaged socioeconomic background, having very little in the way of social support. And we do see that some of those factors are still associated with depression in people with long-term conditions, but sometimes those relationships aren't as strong as we would expect otherwise. And other factors related to the disease are also important. So the picture in terms of causes is a bit unclear. What's also really interesting is that the mechanism that links depression with worse physical outcomes, so things like quality of health, quality of life, and more morbidity and mortality, that mechanism is also unclear. So a variety of physiological and behavioural mechanisms have been suggested. The physiological mechanisms differ depending on the condition, but in terms of behavioural mechanisms, treatment compliance is a factor that's received a lot of attention. So it might be if people aren't managing their symptoms particularly well or adhering to their treatments, then that's leading to worse outcomes. But actually, none of these mechanisms has been proven to explain the link between depression and worse physical outcomes. So hopefully what I've sort of demonstrated is that there's a problem, and actually there's a lot of things we don't understand currently. So what I'd like to suggest is that better understanding the causes of depression in long-term conditions could be helpful for a number of reasons. So first of all, it could help us to identify subgroups of people who are at risk for depression, and possibly also worse physical health outcomes. And what that could do is enable us to improve our screening procedures, and perhaps to provide earlier interventions or preventative strategies. Hopefully, understanding the causes of depression better would also allow us to identify novel targets for treatment. So it might be that because there are some of the traditional risk factors for depression perhaps are not as strong in people with long-term conditions, we might be actually missing other important targets for treatment. So it's important to identify those, and if we can target those for treatments, we can incorporate those. And finally, it might also allow us to inform adaptations to existing treatments. So this is the idea that we might be able to make standardized treatments for depression more relevant to people with long-term conditions. So what I would like to do for the rest of the time I've got is to explain 2 studies to you, which I've been involved with fairly recently. And these are looking at 2 interesting mechanisms that or 2 interesting predictors of depression in people with long-term conditions. And these are in 2 separate long-term conditions as well. So first of all, I'm going to talk about a study which looked at the role of repetitive thought, and especially rumination, in predicting depression in people with coronary heart disease. So before I begin, I'd just like to explain what repetitive thought is, what I mean by that. So this is a umbrella term really for a number of cognitive constructs that are characterized by repetitive, prolonged and recurrent thoughts, usually about a personal concern. They're usually negative and they're usually unconstructive in nature. These are normal sort of processes, so it's important just to point out that these are things that we all engage in from time to time, but when it's difficult, when people find it difficult to disengage from these processes, that's when they can become problematic. So in the context of long-term conditions, it might be that repetitive thought takes the form of spending a lot of time thinking about the causes of the condition, why it's happened, trying to make sense of it. It might involve worries about what the condition means for the person and their life situation. What does it mean for their job or schooling? And also thinking about what the potential difficulties might be in terms of managing that condition going forward. And we know from other work that other types of cognitions about health and illness are important in terms of depression, or in terms of outcomes, sorry, I should say, in long-term conditions. So for example, we know that negative illness perceptions are linked with not only depression, but also worse quality of life. So it's plausible to think that repetitive thought may also similarly contribute. So what do we know about it already? Well, we know that in healthy and psychiatric populations that there's really clear evidence that different types of repetitive thought are predictive of negative mood, of anxiety and depression. But interestingly, we also see that there are links with physical effects as well. So, for example, effects on cardiovascular health, on things like wound healing and immune function. And one explanation for this is a sort of a vulnerability stress framework. So this is the idea that negative repetitive thinking might maintain cognitive representations of a stressor, and it might amplify the effect of that stressor by keeping active physiological stress response. So, and that can lead to changes in cardiovascular system, HPA system, immune system, and those changes will eventually downstream lead to worse physical effects, I should say. So the picture in terms of healthy people is relatively clear. So what do we know in terms of long-term conditions? Well, there's quite a lot of cross-sectional evidence showing that there's an association between various types of repetitive thought and depression. But obviously that sort of work doesn't allow us to say much about causality. So one of the things I did as part of my PhD was a systematic review of prospective studies in long-term conditions. And what we found there was that actually there's not really very much research in this area. And also that a lot of the work that has been done has been quite limited because the quality of the studies that are available is quite low for various reasons. And while the majority of studies do suggest there is an association, a positive one, between repetitive thought at one point in time and the subsequent development or maintenance of depression, there's not really much information on what happens in terms of physical outcomes. So is rumination impacting on disease outcomes, for example? That said, the strongest evidence that we did find was in patients with heart disease and chronic pain related conditions. And that showed that there did appear to be a small correlation between catastrophizing or rumination and later depression. So based on that, and armed with the knowledge that some of the previous research had several limitations, I set out to investigate whether there was in fact a prospective association of rumination with depression and with health-related quality of life, so a physical outcome measure in people with coronary heart disease. And in addition to that, I'd noticed in the previous literature there hadn't been any work exploring the mechanisms by which rumination may impact on depression. So I set out to explore some factors that might help to explain that association, and that then could subsequently be used to as targets for treatment potentially. So the main hypothesis was that higher rumination at baseline would predict greater depression and worse quality of life 6 months later. And I also explored 3 of 4 potential mediating mechanisms that I'd identified, which looked like they could be really interesting. So those were social support, problem solving, and pleasant activities. One of the other things that I would have liked to have looked at was negative cognitive biases, but I wasn't able to do that in this study. So I'm going to focus on the first 3, and I'm going to come back and explain a little bit more about what those are later on. So what do we do? So the study was an observational prospective cohort study, and this was in people who had recently had an acute coronary syndrome. So this was people who had either had angina with a sudden onset, excuse me, or who had recently had a heart attack. So these were inpatients and outpatients, and we collected data via self-report assessments, which were sent out in the post, and those were done at baseline, and then again at 2 months, and then again at 6 months. And that was so we could look at the trajectory of changes in our main outcome measures, which were depression and health-related quality of life, and also in rumination and our potential mediating variables. So we did collect some additional information from the medical notes. So this was to do with disease-related variables, so severity of cardiac disease and functional limitations, for example. And we collected some other measures related to sociodemographics and the psychiatric history from notes as well. So what did we find? So there's a lot going on this slide, but actually the take home here really is that I just wanted to demonstrate that this sample was fairly typical of what you'd expect to see in coronary heart disease. So there were more men, they were slightly older. One thing that was a little bit striking about this sample in particular is that they were actually quite well. So the majority of people had pretty good function after their hospitalisation in terms of their cardiovascular health. They also had relatively good quality of life scores, so only just slightly below what you'd see in the population. And their depression scores, although we saw a similar amount of people who were scoring reaching criteria for depression, as you might expect in a sample with long-term conditions, the actual mean depression scores were quite low. So it's kind of suggesting that this is quite a healthy sample that we recruited. So this is a slight sort of spoiler alert of what's to come, really. So this is cross-sectional data. So this is just at baseline. And we found there that there was a large correlation of rumination with depression and a moderate correlation of rumination with quality of life. And then moving on to the follow-up data, which is the more interesting data, we did have quite a lot of attrition. So we started out with 169 participants, and by the time we got to the 6-month time point, there were 112 left. And it might be that the non-completers were more unwell, and that does seem to be supported by the data on disease severity and depression scores. There wasn't any marked change over time in the key variables, though. So, like I said at the beginning, they seemed like quite a well sample, and it stayed that way as they went through the study. So this is a slide showing actually our main findings. So our main hypothesis was that depression at baseline would be predicted, depression at follow-up would be predicted by baseline social support, baseline rumination, in addition to several other traditional risk factors for depression. And what we actually found was that less social support and greater depression at baseline predicted depression at follow-up, and also that rumination at baseline predicted depression at follow-up. Now, I've said down on the bottom left of the slide that rumination accounted for about 2% of the variance in the model. So the model included our traditional risk factors, things like age, sex, social support, baseline depression. We added rumination in as a separate step so that we could see its sort of unique contribution. And 2% of the variance might not sound like very much, but actually the baseline depression sort of absorbed so much of the variance. I think it's pretty amazing that anything else came through. So we were really excited to see that this prediction of rumination on subsequent depression. What we didn't find was that rumination impacted on quality of life. So that was contrary to our hypothesis. So I said I'd come back to some potential mechanisms that might explain how rumination links with subsequent depression. And the mechanisms that we were able to take self-reports of during this study were social support, and in particular this was the perceived availability of social support. We also took measures of problem solving. There were various subscales in the measure that we used. Negative problem orientation is a particular way of looking at problems and thinking about problem solving. And that was a key subscale that we focused on. And we also looked at pleasant events. So this is how much people are engaging with pleasant and useful events. And all of these things have been shown to be linked with depression. But there's also suggestion in the literature that, well, there's also plausible reasons why rumination might impact on each of these as well. So I conducted some single mediation models using a sort of a causal steps approach based on Barron and Kenny method. And each of these three potential mediators all appeared to partially explain the association between rumination and subsequent depression. So I built these into a single multiple mediation model. And what actually happened here was that both perceived availability of social support and negative problem orientation appeared to partially mediate the association of rumination with depression, and pleasant events dropped out of that model. And social support is quite an interesting one because it's a traditional risk factor for depression, or lack of is. So it could be that actually social support in this model is either a mediator or it could be a confounder of the relationship between rumination and depression. In addition to that, the effect sizes for problem solving were the largest. So my sort of interpretation of all of that is that actually in this context of coronary heart disease, problem solving might be a particularly good explanatory variable in terms of the association between rumination and depression, and it might warrant further investigation as a target for treatments. So I've already said some of this, but this is just to summarise the findings. So we found that rumination is prospectively associated with depression, although we didn't observe any effects of rumination on quality of life. We found that problem solving might act as a partial mediator of the rumination-depression relationship. And this is interesting for a couple of reasons. It suggests that high ruminators might be at increased risk of depression. And that could help with things like improving screening processes for depression in people with heart disease. And it also suggests that both rumination and problem solving might provide novel psychological targets for treatments for depression. That obviously requires further confirmation. Future work, I think it would be really interesting to look at whether problem solving can actually improve depression reliably. And I think particularly in heart disease, that evidence is not there at the moment. So I think that could be a really interesting future direction for intervention. So I'm just looking at the time. I think I'm going to have to rush through my second study slightly. But this second one is looking at the relationship between both disease activity and depression and emotional processing and depression. And this is in inflammatory bowel disease. So I'm just going to explain a little bit about why I think this might be interesting in this group. So it's becoming clear that inflammation appears to be involved in depression. And one particularly interesting finding is that in Crohn's disease, which is one of the inflammatory bowel disease, that anti-inflammatory, a particular class of anti-inflammatory drugs, rapidly reduces depression. And that happens independent of improvements in disease activity. So it suggests that there's some sort of direct link between inflammation and depression. But the mechanism of how inflammation might lead to depression is currently unclear. However, in a lot of long-term conditions, you see chronic inflammation. So in this context, it could be really interesting. So what could explain why inflammation leads to depression? Well, one possibility could be cognitive biases, and that's what we've set out to explore in this study. So first of all, what are cognitive biases? So it's a tendency to preferentially attend to and recall negative information and to interpret events more negatively. And these sorts of negative biases in processing, particularly of emotionally salient information, is central to the development of depression. What's also really interesting is that experimentally induced inflammation in healthy participants also appears to impact on emotional processing. So these different strands of evidence put together could suggest that inflammation may provoke biases in emotional processing, which may then impact on depression. So in order to explore this, we conducted a cross-sectional pilot study in a condition where there's chronic inflammation, so that's inflammatory bowel disease, and that includes both Crohn's disease and ulcerative colitis. And the aim of this study was to investigate whether some of the traditional risk factors for and also inflammation or disease activity, I should say, actually, and emotional processing biases are linked with depression. And what we also wanted to do was to look at whether there was a mediation effect of emotional processing between disease activity and then subsequent depression. So what we did, this is a cross-sectional study. These were adult outpatients. They were recruited in the gastroenterology clinic. We did a number of things. First of all, we collected self-report questionnaire assessments of our sociodemographics and some of our key variables. So our main outcome was depression. That was measured using PHQ-9. We also asked people to complete a computerized task of emotional processing, and I'm going to just show you what that looks like in a second. We collected some information from the medical notes related to disease activity, and we also took a blood sample to measure some inflammatory markers. And that wasn't altogether successful. If I have time to come back and talk about that, I will do. So just to show you what the emotional recognition task looked like, this was a task where we were showing people pictures of just a section of a face, just the eyes, and we were asking them to recognise the emotion that they could see in the eyes. I've put a few example pictures here. These are actually quite easy ones because these are pure emotions, but the images that participants were actually presented with were blended from pure emotion down to a blend which was it was a 90-10% with a neutral emotion. So you can only just barely see the differences. So we were very focused on the happy and the sad faces in this task, and we used that to create an emotional recognition bias score. So we took the proportion accuracy for the sad expressions away from the proportion accuracy for the happy expressions, and that gave us our bias score. And what I should say is that in general, what you find with this is that people actually have a bias towards positive emotions. So they'll recognise happiness inappropriately, actually, in expressions which are otherwise negative. And it's only a slight bias, but that's what tends to happen in a healthy population. And that's where the idea of depressive realism comes from, is that often people with depression are more accurate with this kind of thing. So what did we find? Our sample was looked fairly typical of what we'd expect for Crohn's and UC patients. Again, like similar to the previous study, depression scores on the whole were quite low, but we did see quite a substantial number of people meeting criteria for depression, so about 25%. We had about 30% with active disease, so a lot of people with current flare-ups, and obviously associated with inflammation. And the other thing of note was that we did find and I've just mentioned this, you'd expect to see a positive bias in emotional recognition, and overall that's what we found. But on to the more interesting results. So looking at predictors of depression, and remembering that this is cross-sectional data, we found that the only predictors of depression status were lack of social support and active disease. So our traditional risk factors didn't figure in this model. So what we then did was to look and see, okay, we have these potential predictors, but where does emotional bias or emotional recognition bias factor into this? So similar to the last study, we did a mediation model using the Barron and Kenny causal steps approach, and we found that there was a significant impact of disease activity on emotional recognition bias. And actually what I should say here is that the emotional recognition bias, although overall it was more positive, we found an association with that bias and depression. But what we actually found there was when we found a less positive bias. So we didn't find a negative emotional bias leading to depression, but we found that the people who were depressed were more likely to have the magnitude of their positive bias was smaller. So we found that, in this mediation model, we found that emotional recognition bias was potentially a partial mediator of the association between disease activity and depression. And I think I've got time to just summarise. So we found that both social support and disease activity predicted depression in people with inflammatory bowel diseases, and that emotional recognition bias may partially mediate that relationship. And this is interesting because it might suggest that the higher rates of depression that we see in people with active IBD could be explained by biases in emotional processing. And we could use that information. So it could be that we could identify people at risk of depression using emotional processing biases as a biomarker, and that could help with screening and early detection of depression. It might also suggest that reducing inflammation in people with emotional processing biases could be helpful, but I think that requires more work before we can actually recommend that. Now, it's probably just as well, because I'm running out of time, but what I actually would have liked to have done is to show you some additional data which is related to this. So there were quite a few limitations of this study, not only that it was cross-sectional in nature, but also some issues with measurement of inflammation and disease activity. And we've corrected some of those limitations in another study which has actually been completed, but we're still waiting for some of the work to be done on the analysis of some of the data. So I can't show you that today. So yeah, watch this space. Hopefully we'll be able to confirm these findings prospectively in the not too distant future. So overall, I hope that So just to summarise really what I've said today, I hope that I've convinced you that depression in long-term conditions is problematic because it's common, because it's linked with worse physical outcomes, and also that treatment isn't optimal. I've mentioned that the causes of depression and how depression might relate to worse physical outcomes is unclear. And so what I'd like to suggest is that looking beyond, trying to understand depression better and looking beyond some of the traditional predictors of depression could be really helpful, because it could help us to identify people who might be at risk of depression, so among those with long-term conditions, that is. And it might also allow us then to identify people at risk of worse physical outcomes. It might allow us the opportunity to identify novel targets for the development of interventions, and it might allow for adaptations to existing interventions and for the personalisation of treatments. So I'm going to stop there. Thank you all very much for listening. And I'm aware I've had to scratch the surface with some of those things, so I'm happy to take any questions.